or torsemide. So for this one, you use for patients who do not respond to thiazide diuretic therapy. So for diuretics, we usually start with thiazide. It's very, very good in our black population, elderly. The elderly are the ones who are even coming with this hypertension. However, they are more potent at inducing diuresis compared to thiazide diuretics and can cause even more metabolic side effects. So whatever we were saying, hyponatremia, hyperuricemia, the side effects are worse with these loop diuretics compared with thiazide diuretics. So for loop diuretics, we'll find we're using for patients with heart failure or severe chronic kidney disease, where we require this potency, and we'll see why even we're using it in heart failure, because it also helps relieve the pulmonary symptoms. So it's why we'll find we're giving this patient this loop diuretic instead of a thiazide diuretic. So alpha blockers examples: doxazosin, prazosin, terazosin. They are blocking the alpha-1 receptors, inhibit uptake of catecholamine in smooth muscles, and causing vasodilation. So also effective in lowering BPs, but they have also more side effects than these other first-line drugs. And we can see why we are even putting them in others. So they usually add-ons on you have tried the first-line agents, you've added the second-line agents, and this patient, the BPs are very stubborn. So now we consider even using this other agent. So side effect is hypotension, so it really lowers the BPs. So the patient you're trying to treat for hypertension, and then all of a sudden they go into hypotension. Usually seen with the first dose or with postural changes. That is once they stand up, the BPs dip and they go very low, and the patient faints. So that's a side effect, but you can still use them. Direct vasodilators, examples: hydralazine, minoxidil, working on the arterial vasculature. So on the artery muscles, they just vasodilate those arteries directly. So considered last-line therapy, and this one reserved for specific indications where we are having difficulty in controlling BPs, like a patient coming with hypertensive emergency. We usually use now these direct vasodilators to just lower the BPs, and then they will continue with their other medications, and we stop this. So this one is where we can't control these BPs. The patient is always having high BPs, and they're on like 3 more drugs. So we can use these direct vasodilators. Side effects will cause fluid retention and reflex tachycardia. And we need to use it with a diuretic or another agent that lowers heart rate, because now this one is just causing vasodilation. So we can't just use it alone. So you need to add either a diuretic or a beta blocker, and so on. Central alpha-2 agonists, examples: methyl dopa or clonidine. So we'll call this centrally acting antihypertensive. And these ones are acting in the brain, where they stimulate the inhibitory neurons and decrease sympathetic outflow from the CNS. So when they decrease the sympathetic outflow, it means the vasoconstriction is reduced and cardiac output is lowered, which lowers now the BPs. And for these ones, they have anticholinergic side effects, where a patient now will have sedation, dizziness, dry mouth, fatigue. Some have sexual dysfunction. And although they lower now these BPs, they often cause fluid retention and should now be used with a diuretic. So for here, what you need to know is this methyl dopa is the one that we usually prefer using in pregnant women or in pregnancy. So you can use either methyl dopa or calcium channel blocker like nifedipine and so on. But just note here, this one is usually safe for pregnant women. These are other inhibitors which maybe if you're lucky you'll come across them, which deplete the norepinephrine, either resapine, example resapine, guanethidine, guanadril, Honestly, I've not even come across them, but they are there. So there's this new antihypertensive agent, aliskiren, which is a direct renin inhibitor. Remember renin, where we are talking about, it was being released from the kidney after it was being hypoperfused to convert angiotensinogen to angiotensin 1. So this one, we are blocking that RAS system from the start. So it's a direct renin inhibitor. So of course, similar action, it will just block the RAS system, just like the ACI, ARBS. And it has it's used for hypertension, although I have not come across it. So those are the category of antihypertensive drugs. Please know them. We'll come across them when we are also doing other heart conditions. And I think what I wanted to I've already noted, we do lifestyle modification on top of that, pharmacotherapy also to control the BPs. And note these compelling indications, specific complications of hypertension or comorbidities should be considered when we are starting any pharmacotherapy to treat the patient. So these compelling indications are the ones I was telling you about, their complications which are associated with hypertension. So a patient comes with hypertension and yet they have heart failure already, or coronary artery disease, or they have had a previous MI, recurrent strokes, they have diabetes or chronic kidney disease. Their target for BPs, they need to be very strict, less than 130/80. And here we are considering which drugs do we use. So like for heart failure, we usually choose ACIS with a loop diuretic. So these are just to know. Remember, loop diuretic was in the others, but for heart failure, we usually include it. So this is just to mention what you need to know, because heart failure, I'm going to also go through it. So ARBs and ACIs, we'll find mostly we are using them for this compelling indication, except for CKD. So we usually just favor ARBs or ACIs if the patient has these complications. So I don't think there's anything to add there for heart failure, because heart failure will still cover it. We usually use loop diuretics. They have to be beta blockers. These are usually even now first line for heart failure. So if a patient has hypertension and heart failure, we'll have to treat now the heart failure, as we'll see ahead. Coronary artery disease. So first drug here is usually for beta blockers. Remember what we were trying to reduce the workload on this heart, so reducing the heart rate and contractility. Or we can use now the non-dihydropyridine calcium channel blockers like verapamil and thiazinde. They're usually an add-on therapy to now this other calcium channel blockers like nifedipine. If they have a previous MI, also ARBs are considered to be used on top of all that. And of course, adding on, it depends on how the patient is doing. So this patient, by this time, they have already been referred. So recurrent stroke prevention, we combine thiazide diuretics with ACIs. So if you note what I'm just saying, for this compelling indication, the class of drugs that we go for very fast are the ACIs and the ARBs, are usually the initial therapy, even in diabetes. And then now you can add other drugs, either thiazides or calcium channel blockers. And just note, for thiazide, it causes hyperglycemia. So we really, if a patient has diabetes and it's not well controlled, we avoid these thiazide diuretics. So we need to know all those things. For CKD, if the patient has proteinuria, you will find we are using ACIs and ARBs, but contraindicated in the patient with renal artery stenosis. So still used with good monitoring, because it causes, it actually treats these proteinuria in patients with CKD. So you'll find we are still using ACIs and ARBs even in CKD, but with renal artery stenosis, it is contraindicated. Also, loop diuretics can be used for this CKD because they have volume overload. So So for special patient populations, like in the elderly, we usually say the thiazide, diuretics, ACIS, and CCBs are very good for this category of patients, but we need to monitor hypotension. For children and adolescents, still using ACIs, ARBs, beta blockers, calcium channel blockers, and thiazide can all be drug therapy choices. So for children and adolescents, you can see here we have all those first line agents that we can use. In pregnancy, I think I've mentioned methyl-dopa is what we can use, and nifedipine, and also beta blockers such as labetalol are usually used, but note contraindication of ACIs and ARBs in pregnancy because of the fetal side effects. It can cause that kidney failure or damage to that fetus before it is born. For black patients, I've said what we usually use. We are calcium channel blockers and thiazide diuretics are usually first line, very good for our population. So we recommend starting them on thiazide diuretics plus calcium channel blockers if they don't have any compelling indications, remember. Because for ACIs, ARBs are very good for the white population. But for compelling indications, whether they are black or white, we recommend the ACIs and ARBs. And I think I will stop there. These other ones are just pharmaceutical care plans which you can go through, especially for clinical pharmacy. And of course, now if you have this knowledge, you will be able to counsel these patients on the side effects and all that. And these are the recommended dosages and side effects for this category of antihypertensives. I think I have mentioned all of them. For thiazide diuretics or thiazide-like, I didn't mention thiazide-like diuretics. Example is this clothalidone. You might come across it if you're working in a very good setting or a private setting also. I think I've mentioned about compelling indications and side effects. So you can also go through all those incursions, also comorbidities on drug choice. If the patient either has gout, we've said some diuretics usually increases hyperuricemia in diabetes and all that. So unless anyone has a question. It's 8:36.
Hello.
Yes.
I would like you to comment on when you look at the current management of hypertension. The physicians are no longer really encouraging monotherapies.
Yes.
Also, the manufacturing pharmaceuticals has made it a very convenient of this combination. So I'd like you to comment in line with the first line, second line, and others. Then number two, I would like to, can you consider, we have situations where you can use two diuretics?
Yes.
Okay.
So for the issue of first line and second line, just note what I had said. The first line we had said there is calcium channel blockers, thiazides, which other ones? ACIs, ARBs. When I said first line, it doesn't mean you just use one first line before you go to the second one. The first ones you use even in combination. So you can do an ACIs with a calcium channel blocker or a calcium channel blocker with a thiazide together before you even add now the second line, which is now the beta blockers and the spironolactone and the potassium sparing. So mostly we find we use two drugs, starting with that before monotherapy. Okay, honestly, even in my setting, I don't think there's a patient who's been started on monotherapy and the BPs have been okay. We usually like that combination of drugs. I don't know if I've answered your question. So the other one was on?
Whether you can, as AIS, I've understood.
Yes.
Whether you can use more than, do we have conditions where you can use more than one diuretic?
In heart failure, I think I've mentioned, where we are doing a loop diuretic. At the same time, we are doing a potassium sparing diuretic like spironolactone. So we'll find we are using 2 diuretics in that situation. So for hypertension, the diuretic that you'll find a patient having is that spironolactone. We said it's a second line. And if we are adding, unless we are adding now Lasix, the furosemide. But you really also need to monitor the BPs for those patients so that they don't go into hypotension.
So is it right for you to put a patient on hypertensive, maybe when with them you have talked about the